Hi, this is Cheryl again, and I'm going to be talking today about common cardiac ICU medications. So, on this episode, I will be talking about antiarrhythmics, inotropic and vasopressor medications, inotropic and vasodilator medications, and vasodilator medications. This will be a quick one. The first category is antiarrhythmics. Some antiarrhythmics are adenosine, amiodarone, atropine, digoxin, diltiazem, metoprolol, procainamide, esmolol, and lidocaine. So, adenosine is used for PSVT or paroxysmal supraventricular tachycardia. The therapeutic effects is that it slows the AV node conduction and interrupts the re-entry pathways. Amiodarone is usually treatment and prophylaxis for patients with VTAC or VFib. You remember your ACLS algorithm that's used in that algorithm. The therapeutic effects are that it prolongs the refractory period, that decreases the SA node function and AV node conduction. Atropine is used for acute symptomatic bradycardia. The therapeutic effect is that it increases the heart rate by reversing cholinergic mediated decreases in heart rate. So it speeds the heartbeat up. Digoxin is used for control of ventricular response in atrial fibrillation, atrial flutter, and PSVT. Therapeutic effects increases the force of contraction, decreases conduction through the AV node, decreasing the ventricular rate. Diltiazem uses control of rapid ventricular rate in atrial fibrillation, atrial flutter, rapid conversion of SVT to normal sinus rhythm. Therapeutic effects: calcium channel blocker, slows the SA and AV node conduction and causes atrial vasodilation. Metoprolol, we use it to treat patients with stable acute MI. Therapeutic effects: cardioselective beta blocker, it decreases the heart rate and blood pressure and cardiac output and reduces the severity of myocardial ischemia. Procainamide is used in AFib, PSVT, it's used for VT and PVCs. Therapeutic effects include increases the stimulation threshold of ventricles and the His-Purkinje system, and it decreases myocardial excitability and conduction velocity and depresses myocardial contractility. Esmolol. The uses are for SVT, sinus tach, AFib, A-flutter, intraoperative tachycardia, hypertension. Therapeutic effects are cardioselective beta blocker, slows the sinus rate, it decreases cardiac output and reduces blood pressure. Lidocaine. The uses are for PVCs, ventricular tachycardia, and ventricular fibrillation. Therapeutic effects: it decreases depolarization, automaticity, excitability of the ventricle during diastole. All right, our next category is inotropic and vasopressor medications. These include dopamine, epinephrine, and norepinephrine. Dopamine uses are hypotension associated with shock, bradycardia or heart block unresponsive to atropine or cardiac pacing. Therapeutic effects are dose related. So beta 1 stimulant in 2 to 10 mics per kg per minute increases contractility. Alpha stimulant 10 to 20 mics per kg per minute increases vasoconstriction and blood pressure. Epinephrine uses are hypotension unresponsive to volume resuscitation or decreased chronotrophy, requiring inotropic support. Therapeutic effects are it increases contractility, it increases the heart rate, increases SVR or systemic vascular resistance, relaxes the smooth muscle of the bronchial tree, produces cardiac stimulation. It's a beta 1, beta 2, and alpha stimulant. Norepinephrine uses are hypotension unresponsive to fluid and volume resuscitation. Therapeutic effects, it increases contractility, increases the heart rate, increases SVR, increases systemic blood pressure, and coronary blood flow. And it's a beta 1 and alpha stimulant. Our next category is vasopressor medications: phenylephrine, vasopressin, and norepinephrine. As you can see, norepinephrine kind of falls into two categories. Anyways, phenylephrine, we use it for hypotension, salvage therapy, and septic shock. Therapeutic effects increases SVR, increases systolic blood pressure, and is an alpha stimulant. Vasopressin used as an adjunct in septic shock when vasopressors and fluid resuscitation are ineffective in maintaining goal blood pressure or MAP. Therapeutic effects increases SVR. It's a hormone antidiuretic that causes vasoconstriction, water retention, and urine concentration. Norepinephrine we just went over. Just to repeat it again, its uses are for hypotension unresponsive to fluid volume resuscitation. It increases contractility, heart rate, and SVR, and increases systemic blood pressure and coronary blood flow. And it is a beta 1 alpha stimulant. Okay, let's go on to inotropic and vasodilator medications, dobutamine and milrinone. Dobutamine is used for cardiac decompensation. It's a positive inotropic agent in myocardial dysfunction and sepsis. Therapeutic effects. It decreases preload and afterload and enhances myocardial contractility, stroke volume, and cardiac output without increasing oxygen demand. It's a beta 1, beta 2 stimulant, and it improves renal blood flow and urine output by increasing cardiac output. Milrinone is used for short-term management of heart failure, although I've seen it, people go home with it. So it can be used long-term. Positive inotropic agent when unresponsive to other therapy. Therapeutic effects. Phosphodiesterase inhibitor. Relaxes vascular muscle, causing vasodilation. It decreases preload and afterload, resulting in increased cardiac output. Increases contractility. I'm all over the place with this milrinone. It's mostly seen like in heart failure. Vasodilator medications: labetalol, nicardipine, nitroglycerin, and nitroprusside. Labetalol uses as management of hypertensive urgency and emergency. Therapeutic effects are alpha, beta 1, beta 2 blocker. It decreases SVR without reflex tachycardia. Decreases blood pressure, moderate decrease in preload and afterload. Nicardipine uses management of hypertension. Therapeutic effects are calcium channel blocker, it depresses vascular smooth muscle contraction, it decreases the SVR, increases heart rate, and cardiac output. Nitroglycerin uses acute coronary syndrome. Therapeutic effects, it dilates coronary arteries and improves collateral blood flow to ischemic areas in the myocardium. Decreases myocardial oxygen demand and increases peripheral vasodilation. It does strong preload reduction and mild afterload reduction. Nitroprusside uses hypertensive urgency and emergency. Therapeutic effects are potent vasodilator, acts directly on arterial and venous smooth muscle, decreases SVR, moderate preload reduction, and strong afterload reduction. So there you have it. Our vasodilator medications, our inotropes, vasopressors, and antiarrhythmics for you. Hope that helped.